everyone. It's nice to meet you, and thanks for having me today. I'm Christina Lee. I'm a psychiatrist at UC Davis, and I work here locally in Sacramento, so it's wonderful to be here with you. I'm going to be talking about behavioral and mental health considerations in Wilson's disease. I don't have any disclosures to share. So why is this topic so important? Well, the quality of life in Wilson's disease is often closely tied to psychiatric status. And as many of you may know, as patients, families, and caregivers, that the presence of psychiatric symptoms can often have a big impact on life in Wilson's disease. And when they go unnoticed or untreated, they can potentially affect someone's ability to engage or adhere to treatment or potentially long-term prognosis. So when do psychiatric symptoms typically present in Wilson's disease? Well, for about 20% of patients, psychiatric symptoms actually present before diagnosis and can occur as early as childhood, sometimes more as nonspecific symptoms like poor academic performance in school, and sometimes this can lead to misdiagnosis, although more commonly symptoms will start to present as more classic psychiatric disorders by early adulthood. About 30 or 40% of patients will typically have psychiatric symptoms when they are diagnosed. And then there are some studies that show that almost all patients with Wilson's disease will unfortunately have some form of psychiatric symptoms across the life course. Our ability and timing to accurately diagnose Wilson's disease also is impacted by what are the initial symptoms. So we actually are best at recognizing Wilson's disease earlier when the initial symptoms are due to liver damage, typically in about 6 months' time. However, we are usually more delayed in identifying Wilson's disease when the first symptoms are neurologic and psychiatric. And in fact, when psychiatric symptoms are the first symptoms, often it takes us up to over 2 years on average to identify Wilson's disease. And you may be asking yourself, why is that? Well, unfortunately, a lot of the psychiatric symptoms in Wilson's disease present similarly to psychiatric symptoms in the rest of the population. So it makes it really hard for us to figure out when Wilson's disease is the underlying contributor until some other liver or potentially neurologic symptoms are presenting in combination. Most patients typically demonstrate improvement in psychiatric symptoms with anti-copper treatment in the long term. However, I did want to make note that some patients may experience what we call this paradoxical increase in neurologic and psychiatric symptoms in the first 6 months of anti-copper treatment. I think this agent is a little bit less used today, but D-penicillamine is an example. The chelation process involves the rapid removal of copper from liver and other tissues in our bodies, but this can lead to an increase in copper levels in our blood circulation, and this can lead to increased exposure to the brain, which then leads to increased potential exacerbation in neurologic and psychiatric symptoms. Some of you may have heard of Wilson's disease being nicknamed the Great Masquerader, and we call it this sometimes because it can present with a lot of different symptoms, because it affects a lot of different organ systems, and this includes in the mental health arena. It can present in a number of different ways. These are some of the most common, including mood disorders, psychosis, behavioral and personality changes, anxiety, and cognitive impairment. And we're going to be going over each of these in a little bit more detail today. Depression is often characterized by weeks or sometimes months in a row of periods of low mood. Patients will often feel difficulty with motivating themselves to do things. They'll have trouble enjoying activities they normally liked before. They might have changes in appetite, either increased or decreased, feelings of hopelessness or worthlessness, low energy, difficulty with sleep, and sometimes this can progress to have suicidal thoughts or attempts at suicide. This affects about 20 to 60% of patients with Wilson's disease, and unfortunately this population also has higher rates of suicide attempts, about 14 to 16% across the lifetime, and this is higher than the general population of about 5%. So as providers, patients, and caregivers, this is something that's really important for us to monitor. Our treatment approach in depression is similar in the way that we treat depression in the rest of the population. We most often will reach for antidepressants. There are many different types of classes of antidepressants. These are some of the most common that we reach for because they tend to be the best tolerated, and that includes selective serotonin reuptake inhibitors, SSRIs, or serotonin norepinephrine reuptake inhibitors, SNRIs. Sometimes when patients don't respond to medications, we'll reach for more interventional approaches, such as electroconvulsive therapy. And this involves inducing a seizure, and this has evidence in helping to improve depression. I know that may sound a little bit overwhelming, and I think that comes a little bit from stigma of the way that ECT has been portrayed in the media, but actually it has progressed to a form of treatment today that's quite safe and tolerated very well, and it's done under anesthesia. Psychotherapy also has a lot of evidence in depression, and I'll talk a little bit about that later in the presentation as well. The main kind of medication side effect that we're keeping in mind in Wilson's disease are potentially medications that have a higher risk of liver injury, which, as you know, is something that many patients may already be prone to in the disease. Bipolar disorder, I think, is a condition that is often misunderstood by many of my patients. A lot of people worry that if they have a lot of rapid mood fluctuations in the day, that they might have bipolar disorder, when in fact, bipolar disorder is actually characterized by more prolonged changes in mood, typically days to weeks of changes in mood. Most often when people are feeling unwell, they will spend more time in depression, but occasionally they may have these episodes that we call hypomania or mania. And these are episodes that have a cluster of several symptoms together, typically mood changes like feeling more irritable or feeling more elevated or euphoric, having a decreased need for sleep, talking really fast, thought process becomes more disorganized, and it can progress to include more reckless and impulsive behaviors that put people at risk. Mania typically is a more severe version of hypomania. It usually lasts longer and also typically results in more impaired functioning and ability to care for yourself, and typically will prompt a need for hospitalization. This condition affects about 14 to 18% of Wilson's disease patients, and our treatment approach generally involves using mood stabilizers. Many of you may also recognize some of these medications as anti-seizure medications. In the field of neurology and psychiatry, there are a lot of medications that we have overlapping use. Antipsychotics, also some of them have mood stabilizing properties, and so we will sometimes use those medications in bipolar disorder as well. Some of the most common ones that we will often reach for in Wilson's disease include olanzapine, quetiapine, and clozapine. The main kind of drug interaction that we're keeping in mind is that some antipsychotics may have a higher risk of something called extrapyramidal side effects or movement side effects, which is something we need to be careful with, as this can potentially worsen pre-existing movement symptoms in Wilson's disease. Psychosis is described often as difficulty distinguishing from reality. It's often characterized by difficulty with organized thinking. Sometimes people will develop auditory or visual hallucinations. They can have paranoia and kind of fear of persecution or someone trying to harm them. They may have delusional beliefs. Some common diagnoses that patients may be diagnosed with include schizophrenia. Schizoaffective disorder is a combination of having both psychotic symptoms and mood symptoms together, and delusional disorder, which is more where their delusions have more of a specific theme or focus. Usually, actually, psychosis is relatively rare in Wilson's disease and not necessarily more frequent than the general population, although it has been found to occur more frequently in patients who have neurologic symptoms of Wilson's disease. Our treatment approach typically involves using antipsychotics, just similarly as I was mentioning in the previous slide. I did want to make one note about the medication clozapine. This is a very highly effective treatment for psychosis, but we generally reserve it as a second-line agent after patients have not responded to other antipsychotics. And the main reason is it has a small but increased risk of certain side effects. One is that it can potentially suppress the immune system by decreasing something called white blood cell counts. And some of our copper chelating agents also have a small risk of this, so we want to be careful about combining agents that might have a similar side effect risk. Clozapine also has a small increased risk of seizures, especially at higher doses, so this is also a medication we want to be cautious with for any Wilson's disease patients that have epilepsy. Behavioral and personality changes are also unfortunately quite common. This can include things like irritability, aggression, impulsiveness, inappropriate or bizarre behaviors, social disinhibition, or difficulty determining what is appropriate social behavior. This can affect about half to up to 70% of patients and can lead to a lot of social and family challenges, including issues like divorce, unemployment, even criminal activity. and if it goes unaddressed, potentially can affect someone's ability to engage in care. The bulk of our treatment approach for these symptoms typically involves behavioral therapy, although there are some medications that have some off-label indications for helping with some of these symptoms. For example, antidepressants have some evidence in helping to reduce irritability. Mood stabilizers and some anti-seizure medications can sometimes also help to reduce irritability, decrease impulsiveness, or stabilize mood fluctuations. And then propranolol is a blood pressure medication at lower doses, can also sometimes help with impulsivity and irritability. Anxiety is typically characterized by symptoms of more persistent worry or ruminations, panic attacks, or even social anxiety. It can affect about 20 to 60% of patients, and our treatment approach typically involves using antidepressants. And I put this in quotes because even though we call them antidepressants, they're medications that can treat many things, including anxiety. A lot of anti-seizure medications like gabapentin and pregabalin also have evidence in anxiety, and there are other anxiolytics like buspirone or benzodiazepines, although we tend to be a little bit cautious with benzos because there's a risk of dependence, and so it tends to be more effective if used sparingly. Psychotherapy, like in depression, also has a lot of evidence in anxiety as well. Cognitive changes can also occur. This can include things like changes in ability to sustain attention, trouble with planning or organizing tasks, visual spatial perception and reasoning difficulties, learning and memory challenges, or verbal and abstract thinking difficulties. Usually if it's present at the beginning of the disease, it tends to be mild, but it can potentially progress throughout the disease course and potentially become more mild cognitive impairment or even a diagnosis of dementia. And typically the underlying reason for this is due to copper accumulation in the brain. There have been studies that have shown that higher free copper levels in the blood can be associated with cognitive decline. Unfortunately, we don't necessarily have specific treatment available to target this, though there is evidence to show that anti-copper treatment and liver transplant in the case of liver failure can help to improve cognitive changes. Traditional dementia medications that we usually use to try to slow cognitive changes in more neurodegenerative dementias like Alzheimer's, unfortunately don't have a lot of evidence in Wilson's disease. Other disorders that we don't have time to get into today but can be associated in Wilson's disease include substance use disorders. Catatonia is a neurologic and psychiatric syndrome where patients sometimes have difficulty with moving, speaking, or have other neurologic disorders or even eating, and they usually require hospitalization for treatment. Anorexia or decreased eating, obsessive compulsive symptoms, or changes in sleep. So psychotherapy is a potentially really effective modality to consider for treatment. There are many different types of therapy. These are just a few that I think particularly could be helpful in Wilson's disease. Supportive therapy is more of kind of like a conversational therapy approach where the counselor is kind of talking to you about the specific stressors in your life and helping you to navigate how to get through that. Cognitive behavioral therapy, on the other hand, is a more structured therapy where typically the focus is on identifying automatic negative thoughts that may contribute to symptoms like anxiety and depression, and to reframe those thoughts, and then also learning specific coping strategies that you might implement in moments that you feel more emotionally overwhelmed. Family therapy may also be helpful, and then group therapy and support groups can also be really helpful as well. And I wanted to put a plug in for the support group meetings that are posted on the Wilson's Disease Association website if you're looking for one more locally for you. So just the key takeaways from today are that psychiatric symptoms are common at every stage of Wilson's disease. Wilson's disease we often call the great masquerader because it can present in so many different ways, including psychiatrically. And unfortunately, when psychiatric symptoms are the initial presentations, it can potentially lead to more delayed diagnosis. Anti-copper treatment typically leads to improvement in neuropsychiatric symptoms. And psychiatric treatment in Wilson's disease, the approach is very similar to treating psychiatric symptoms in the general population, but we're a little bit extra mindful of medications that might have an increased risk of changing movement symptoms, liver function, or have an increased risk of seizures. And finally, the timely diagnosis and treatment of psychiatric symptoms can be really important in improving health outcomes. These are my references. That's it.